Good afternoon, everybody. A warm welcome to you all to already this seventh webinar of the Pandemic and Disaster Preparedness Center. Today, we have a topic that is very close to my heart, namely underserved groups. Because what we all knew before, but got even more clearer during the pandemic, is that one size does not fit all. So one approach in reaching out to all groups in society will not work, and some people will be left behind. So hence the reason that the PDPC worked on the Underserved Groups project, and I'm proud that the report will also be launched today. We have a very interesting program for you, and I will introduce the program to you shortly. But before that, I have some practical issues. You can ask your question in the Q&A, and you can also upvote the question. So if you see a question that's very interesting, you can vote for that and that will come up higher. We will also stop sharp at 1 o'clock. So 1 minute before that, I will stop the discussion so we can have a nice wrap up at the end. And it's also good to know that this webinar is recorded and will be shared through our website at the end. So let's have a look at the program. So we have next slide, please. Next slide, please. Yeah. So first we'll have an introduction by Nora Buneman and Valerie Iron from the PDPC. Then we have a presentation by Catherine Bach-Habestad from the WHO Regional Office of Europe. And then we have a presentation of Matthijs Lamboy, also from the RIVM, the National Institute for Public Health and the Environment. And last but definitely not least, a presentation by Dr. Shakib Sana. And then we'll have 15 minutes, hopefully at the end, for Q&As. So we'll have some clarifying questions after each presentation, but we will keep the discussions at the end, for the end. Okay, then we'll go to the first speakers, my dear colleagues Valerie Iron and Nora Buneman, who have been working at the PDPC project, Underserved Groups, for quite some time now. They have both have an excellent background in either international health and global health, and also in the field of dealing with underserved groups. So please, Valerie and Nora, the floor is yours.
Thank you, Anja, for the introduction. Next slide, please. So in 2022, the PDPC initiated the Underserved Groups project, and today we will release the report entitled Barriers and Drivers Influencing People's Behavior Towards COVID-19 Public Health and Social Measures in the Netherlands. So why did we initiate this project? Well, as we all know, the disease burden of COVID-19 infection, morbidity, and mortality is unevenly distributed across different population groups. Furthermore, the COVID-19 vaccination acceptance and uptake is unevenly distributed across groups. A possible explanation is that public health and social measures, including testing, vaccination, and other measures, such as home isolation, were not aligned to the needs and circumstances of people and communities. A one-size-fits-all policy and practice approach risks excluding population subgroups, suggesting there's a need for targeted public health interventions that reflect the beliefs and needs of these groups. Identifying barriers and drivers for specific groups is essential in order to develop tailored health interventions. Next slide, please. So how can this be done? Very briefly, the WHO has developed the Tailoring Health Programs approach, which serves as a diagnostic guide aimed at identifying population subgroups with a suboptimal uptake of a health behavior, and hence capturing the related barriers and drivers. And these behavioral and cultural insights are used to develop tailored interventions, contributing to improve public health outcomes and to address health inequities. And Catherine will elaborate further on the THP approach and provide examples later on. Next slide. So we carried out the first phase of the THP approach, the situation analysis. And the objective was threefold: to identify the population subgroups with a lower uptake and adherence to COVID-19 public health and social measures, to create an overview of previously identified barriers and drivers of the general population and population subgroups, and to create an overview of interventions and research done by various stakeholders in the Netherlands. Next slide. So the situation analysis is based on a literature scan, semi-structured interviews with 23 experts and an expert meeting held last year, October, in collaboration with the WHO Europe. And the results were categorized according to the capability, opportunity, and motivation framework to understand behavior towards COVID-19 public health and social measures. So the literature scan revealed multiple population subgroups have been studied regarding their barriers and drivers for their uptake and acceptance, adherence to COVID-19 public health and social measures. And various groups were also mentioned by the experts in the interviews and expert meetings, such as the slide shows, people with a low socioeconomic status, migrants, older people, homeless people, etc. Now I will hand the presentation over to Nora, who will continue with the results.
Thank you, Valerie. As Valerie mentioned, we analyzed the findings of the interviews and the literature according to the COM-B method, and we identified multifactorial barriers and drivers. Some of the barriers that we identified are lack of trust, distance to services. Some of the barriers we identified among the general population and among specific subgroups of the populations, although some barriers were also more frequent among specific population groups. And some of the drivers that we identified were drivers such as wanting to protect others, or the motivation of things getting back to normal, or trust in science and fear of getting ill. Next slide, please. In the absence of government interventions, we saw multiple interventions popping up and to address various barriers and drivers. I'll only touch upon them briefly, since two of our experts will talk about two interventions in detail. In total, we identified over 45 interventions and research projects. Some of the interventions that address barriers and drivers were, for example, the doubt line, where Shakib will talk about later in his presentation, or the vaccination buses, which, for example, addressed barriers such as distances to services. Next slide, please. During our report, we also came up with a definition of underserved groups, which is as follows: population subgroups with a lower uptake or acceptance to get vaccinated, tested, or adhere to other measures. They may also have different barriers and drivers compared to the general population, face barriers accessing healthcare services, and were possibly not reached through the national campaigns and health strategies. Next slide, please. So what we found is that most of the research was quantitative and addressed the general population and then specifically the vaccination behavior. There's limited research among subgroups, specifically in the Dutch literature. There is a lack of research among disabled people, refugees, and migrant communities. Mostly barriers were identified. This also was found during our interviews. The experts that we interviewed mostly named barriers and, to a lesser extent, drivers. Social factors play a very important role as barrier and driver among the general population, but also among various subgroups. Key figures such as religious figures or GPs play a very important role within interventions. And there's also a lack of monitoring and evaluation of interventions. And although behavioral insights offer very promising instances of employing behavioral insights, there is still a lack of monitoring and evaluation, especially to show the cost effectiveness of these interventions. Next slide, please. And some of the future research questions or also actions that are needed and came as a result of our research is what are the multifaceted barriers and drivers of different underserved groups? What role do family members and caregivers play? But also how can we involve them in interventions and as a source of information? And also how to tackle disinformation and lack of trust, since that was one of the biggest barriers and also most difficult barriers that we identified towards government institutions, but also science and vaccines and the healthcare system. And most importantly, also, how do we translate these findings to targeted interventions? Next slide, please. One before. Lastly, I would also like to thank all the experts and researchers that contributed to this report.
Thank you, Noah, for your excellent presentation, and thank you for all your good work and the work of Valerie and you, but exactly like you said, with all the people who are working together in this. The next presentation will be by Catherine Bach-Habestad. I had the pleasure to work with her for already over more than 7 years ago. Catherine has a background in communications and international development. And I think Catherine works already almost 10 years now for the WHO Regional Office for Europe as a regional advisor on behavioral and cultural insights. Catherine, the floor is yours.
Thank you very much, Anja, and thank you for inviting me to speak here today. Yes, so I lead the Behavioral and Cultural Insights Unit in WHO Regional Office for Europe. And if you take me to the next slide, this is a unit that is rooted in the notion that it is very difficult to find a health challenge today which does not have a behavioral component. These may be the behaviors of everyone in our everyday lives, lifestyle behaviors. These may be the behaviors of patients, of parents, of caretakers, or of health workers. And if we want to tackle some of the persistent public health challenges of today, including pandemics and disasters, we have to be able to understand and explore the barriers and drivers to these behaviors so that we can support, enable them, promote them effectively. And that was the notion that led to the decision of all of the member states in the European region in 2020 to establish a program on behavioral and cultural insights for the first time ever. The European region is large and diverse. It's 53 countries in Europe and Central Asia, so it's an extended European region. And for the first time, it was decided to make behavioral and cultural insights not just a unit, but a flagship program, so a priority for the region in those 5 years that we're currently in. And if you take me to the next slide, we're working in many different ways on behavioral and cultural insights, but an important part of our work is to support with advancing the use of behavioral and cultural insights for health with the public health authorities across the region. And an important milestone was last year in September when a resolution was adopted at our highest governing body with all of the member states adopting a resolution and an accompanying action framework with quite ambitious strategic commitments to this area of work, which has allowed us to establish a community of practice with representatives of all member states to implement this 5-year action framework. As part of this, we're doing a lot of capacity building activities. We have online trainings, in-country trainings, regional face-to-face trainings, lots of meetings and workshops to really build the capacity and support public health authorities and everyone else in all places who would like to use these approaches. And as part of this, we have also launched a new version of our approach to this area of work. It's a comprehensive guide. We call it the Tailoring Health Programs Guide, or THP. And I'm just going to say a little bit more about THP because, as it was mentioned before, this was the document or the approach that was used for the public health and social measures project that was done. And if you take me to the next slide, the Tailoring Health Programs approach has been developed over a 10-year process in WHO, originally developed for vaccination, but now used across any health area. Really been tested, been used in more than 20 countries. And every time we went back and we refined and we improved, and we've had an external evaluation group also evaluating it at some point. And now we've launched this new version, which we really feel is quite sound and solid because it's building on so many years of experience and really listening to those using it and revising it accordingly. It offers a fairly simple 4-step approach or 4-phase approach, as you can see here, with a number of underlying steps. It is, however, guided by a theoretical model which is applied throughout, and also a theory of change. And I think where it adds a lot of value for many people who use it is the toolbook, which is an integrated part. So for each of all of these steps, there's very rich and very comprehensive guidance in the toolbook. So if there is a step that is called prioritize, well, then in the toolbook, you will find the criteria used for prioritizing. And you will also find an exercise with very clear steps that a working group can go through a prioritization exercise and applying those criteria. And you can find it online. And if you take me to the next slide, the THP covers what we also define as behavioral and cultural insights. So it covers everything that we think is within behavioral and cultural insights. It's about understanding who has low uptake of a certain behavior, and then understanding all of the barriers and all of the drivers that affect that behavior. And importantly for us, it's not just the individual factors, the knowledge, the attitudes, the perceptions, the health literacy, but very much also the contextual factors, the health service provision, the social factors, and the cultural factors, not least. And this is where you find the explanation why we're not called the BI unit, but the BCI unit, the Behavioral and Cultural Insights unit, something that is very important for our member states, that we have this, let's say, holistic approach to behaviors where we are considering the contextual factors as well. But importantly, can we go back, please? Not just gaining the insights, but using that to inform evidence-informed health policies, health services, and health communications that are effective in addressing, promoting, supporting, enabling health behaviors, which then through that can improve health, well-being, and reduce inequity. And then an important part of this work is evaluating those interventions, using rigorous methods, understanding what works where and for whom, and there's guidance on that in the document as well. This is an approach that can be used across any health area, any health topic. It can be used for long-term routine health challenges, but also in a more rapid form during emergencies. We feel, and also originally developed it for focusing on those groups that are underserved. And if you take me to the next slide, please. These are just a few examples of projects that we're currently working on with this approach. We're being approached often by public health authorities in countries that would like to tackle a persistent, difficult health behavior, maybe in a specific population group. And then we work with them using the THP to explore these barriers and drivers and evaluate evidence-informed interventions. And as you can see, there are just a few examples here: breastfeeding, quality of care in hospitals, hypertension treatment adherence, colorectal cancer screening uptake. So, and as you can see also across the board, across very different country contexts, these are just a few examples. But the one example I wanted to just share a little bit more detail on is the last one. And if you can click once, it's just the one where we have to do with a potentially vulnerable and very underserved population groups. That is the Ukrainian refugees in host countries that fled the country and arrived in these 5 hosting countries. And I'm just going to say a little bit more about these studies before we reach the end of my presentations. If you take me to the next slide. These are studies that were led by Martha Scherzer, who's the senior consultant in the team. She was working with the local WHO office, but also definitely this was led by the public health authorities in the 5 countries. Qualitative interview studies in all of the 5, with 3 months in between. So we were able to go back and see if there was any change among the people who'd been interviewed. And the objective was to inform the national response and health service provision to this very vulnerable group. And if you take me to the next slide, as you can imagine, there is a lot of very rich insight from each of the individual countries that I won't be able to cover here, but we were also able to see some things that were quite similar across the countries. And I'm just going to give you a few examples. The first one is that the referral system and the prescription systems were very different from what refugees had experienced back home in Ukraine. And they found it very difficult to manage, very difficult to understand, a lot of waiting time. They really needed more information. They needed to better understand and be guided on how these systems worked. We got information about who they trusted, if you click again, and which format they'd like information to be shared in. Also, interesting enough, one more, we found, and that was a bit of a surprise to us, we weren't aware of how big an issue dentistry was, and how difficult people found it to access, waiting times, very expensive, and they really needed it. And then another example, last but not least, we knew that many people had not had declined mental health services, but we really didn't know why. And it was clear from what they were saying, there were several reasons. For example, many of the refugees were taking care of others. They were taking care of elderly and children, and they didn't know what to do with the people they had to take care of while attending a service for themselves. So there was a very clear practical provision barrier. But in addition, the types of services, group counseling, weren't really what they wanted. They wanted individual counseling. So that was another lesson learned. And if you take me to the next slide, all of this information was incredibly helpful in all of these 5 individual countries to support health service provision, supporting family physicians and how they could make their clinics more inclusive for refugees, how they could support NGOs in the countries who are offering a lot of service to refugees in many places and who are really trusted by refugees. In some places, the solution was also to engage Ukrainian-speaking cultural mediators who had some kind of health or medical background, so that they could mutually, let's say, translate not just the language, but translate understandings between health workers and refugees, and also information was provided to the telephone hotlines. And the last thing I want to mention about this was we had a high-level meeting in Bratislava earlier this year, and it's the first time I've been to a meeting. It was about refugees in these countries and more, and it's the first time I've heard the refugee perspective being highlighted so much, because we had this rich information. So that the mere existence of this data helped raise the awareness of the importance of refugee perspectives in planning health services. And that's it from my side. And I see you're already on, Anja. So
yes, thank you so much, Katrin, for sharing your experiences and sharing with us how all these behavioral insights can also be translated into interventions and how that works. I think we have room for 1 and 2 questions from the audience. I don't see any in the chat, but maybe somebody has a clarifying question for now. No, nobody. Okay, then we'll move on, and we'll probably have some nice discussion at the end about how we can share this knowledge that you have just shared with us. Then we go to the next speaker. The next speaker is Matthijs Lamboy. He works as a researcher at the National Institute of Public Health and the Environment in the Department of Behavior and Health. And during the pandemic, he was a team leader on willingness to vaccinate at the Corona Behavioral Unit. He also works at the University of Rotterdam at the Erasmus School of Health and Policy and Management, and is also an associate professor. And he will share with us some of the insights of his research on vaccination buses. Matthijs, the floor is yours.
Thank you very much, Anja, and also thank you for the opportunity to tell you about the work I did in cooperation with my colleagues of the Behavior Unit at the RIVM and the Center of Epidemiology and Surveillance of Infectious Diseases. This was a good and constructive cooperation. Next slide, please. Yeah, Anja already introduced me. And what is maybe also nice to know that when the pandemic rose, the role of the team leader of the vaccination was to be an information hub between the municipal health services and some of the nationally operating organizations, such as the vaccination program and the ministries of health and also other ministries. So there I tried to converge the practical challenges and the policy challenges and translated them into researchable questions. And then with the behavior unit, we either set out questionnaires or experiments or other types of research to address all those questions. And one of the topics, next slide please, was the mobile vaccination units. We saw that there were a number of neighborhoods where the vaccination rates were low. And the municipal health services, they took the initiative to deploy these mobile units, which either consisted of the buses or could also be at the pop-up locations. So an empty store was being opened, and they were able to put their refrigerator and a laptop to reach out to the communities to facilitate the vaccinations. The vaccination outreach was also flanked by information, by the opportunity to ask questions and to interact with all the people. And its appearances were being broadcasted by internet, by key figures in the areas, active persons in the neighborhoods. The next slide, please. We saw that many of the neighborhoods where there was an over-representation of the people with migration background, also younger people, and also lower educated people. There were living in the neighborhoods where the uptake was lowest. And the expectation was, well, if we ease the access to the vaccination location, it could be a way to increase the uptake in those neighborhoods and to reach out to the people living there. And during the talks we had with the municipal health services, we had the impression that it was working extremely well. I was talking to the people over there who were in the buses, and they said, yeah, we see people, we don't see at the mass vaccination services. So we are believing it works. But there was no hard evidence. And because of the role we had, we were able to combine the data from the vaccination of all of our country with those of the municipal health services. So we tried out where we could statistically see whether these reach out activities actually worked. Next slide, please. So our question was, do we actually see a change in vaccine uptake when the mobile vaccination units are there? We were able to combine the COVID information management system, where all the national level data on the vaccines, if the people consented at least, was being registered. We were able to combine this with the registry data of where the pop-ups and the buses were at the neighborhood and at a specific time. And there were also 5 additional regions who were willing to give us their extra data on also on the pop-up data. And this enabled us to study 16 of 25 municipal health regions in the Netherlands and to see whether we saw a change. Next slide, please. The time period we took was between September 2021 and December 2021, and we took this because it was after the first wave of the mass campaign, and a lot of the people who wanted to have a vaccine were already vaccinated, and it was prior to the booster campaign, so we had as little distortion as possible. Next slide, please. Here you see the part of the Netherlands we could include. The white bars are the data we have in the data set, and the green and the yellows are where the units were deployed. Next slide, please. We used a regression analysis, and we used splines to see whether we saw the differences, and this enabled us to compare the datums where the units were to their own, and to also other neighborhoods. Next slide, please. Yeah, we have a preprint online, so if you want to get into all the details, you can access the link. But the essence of what we tried to do is, if you see all the diffusion curves here, we try to look for spikes in these diffusion curves where you would expect it. Yeah, next slide, please. Thank you. Well, here we see stratified by urbanization the relative effects, and you can conclude a couple of things from these pictures and these numbers. The effect of the units were strongest at the lowly urbanized regions, and they were less strong in the urbanized regions, but overall the effect was positive. And also, if you just look at the relative rates, sometimes extremely positive, up to 14 times higher, but you have to bear in mind the total deployment compared to the whole vaccination campaign was low, but this seems a promising way to reach out to the vulnerable populations. Next slide, please. Yeah, because the relative rates don't give all the information, we also computed the absolute rates, and I see these are old slides. And the absolute uptake, and this is the differences in percentage point uptake of the total. So you should interpret this for the not urbanized regions. the total uptake went, for instance, to 85% to 85.33%. So the effect, the absolute effect is still a bit modest. Next slide, please, which will be, oh yeah. One other finding is it worked stronger. The effect was stronger for the people with religious conviction, and it was still positive, but not as positive as average for the people with the migration background. Next slide, please. Yeah. Well, here is an overview, and our interpretation is because we see such a strong effect of urbanization grade, we think that ease of access and the travel time is an important thing, an important part of the explanation. And we also see that, well, if you want to reach out to the immigrant people, it could be even stronger even than we would have hoped. Next slide, please. That will be it. Thank you.
Thank you so much, Matthijs, for your very interesting presentation. I see a question in the Q&A. Thank you. Martin Seldenrus is asking the following. Matthijs, you mentioned that young people were overrepresented in the underserved population. Should we consider young people in general as an underserved group for health programs and government communications about health? So maybe you can answer this question first, and then maybe during the discussion we can discuss it further with the other speakers on this.
Well, considering this question in the COVID vaccination, I think we saw that the risks were different for the young people than for the older people. So there was some kind of understanding why they were less eager to get the vaccination. Your question considering other health behaviors, I think we should be careful to look at it at behavior per behavior and the risk and the benefits per behavior. I don't think we can generalize this to all behaviors.
Okay, thank you. Okay, thank you. Then we go to the next speaker. That's Dr. Shakib Sana. Shakib is a general practitioner, but also a PhD candidate at the Erasmus School of Social and Behavioral Sciences. And I think a lot of you have seen him also during the COVID pandemic when he was on the streets reaching out to people who seem to be underserved. And he will tell a little bit about his experiences and also about his insights that he gained during the pandemic. Shakib, the floor is yours.
Thank you very much, Ania, for this introduction.
Micah will share this. Oh, okay, sorry. Micah, are you sharing the slides? Yeah. Okay.
Yes, thank you very much. Yeah, it's all about the behavior, as you saw in my first slides, and I think the other colleagues have also pinpointed out the importance of behavior. And we saw, as a GP, we saw not only in 2021, but in 2020, with the start of COVID pandemic, that the health gap became visible in the first months during the lockdown. That was not only the patients who were infected most by COVID-19 and who are the patients who died, but we also saw that access to the practices, to GP practices, and to the healthcare system as a whole, yeah, so it was also very minimized, and that health gap, but it was, and we see that not the patients are working in the deprived neighborhood, and I saw that my patients from a deprived situation, they were infected about 2 times more than my patients who were not from deprived neighborhoods. One reason is that they could actually save themselves and work at home, but my patients who were working at a cleaning department, or who were working as a bus driver or in the sterilization center of the hospital, they had to go to their work, and all those movements that caused that they also get more infected with COVID-19. And also the chance to die of complication of COVID-19 is also higher, about 2 times, 1.6 to 2 times higher by the patients coming from with a migration background, and also being infected or dying is also higher in my patients or in the patients in general from with lowest incomes. Actually, we see in general that the people from with migration background, they are overrepresented in the low social economic status. Do I have my, yes, I have it. Okay, the next slide, please. So what we see is that people from the low, during the vaccinations, we started a mass vaccination program here in the Netherlands in January, and about in a couple of months, 3 or 4 months or 5 months, we had about 70 to 80% of the population was vaccinated. But what's a journal, an average, those people were vaccinated. But when we started vaccination at of 60 years and above, at our practice, we saw about only 30 to 40% of those people from migration background, from low social economic class, they come to get their vaccines. This was actually also led to the pressure on healthcare, especially in hospitals. But there was also a risk of that this low vaccination rate will increase the chance of a virus reservoir and then of reinfections. And as my colleagues mentioned earlier, this is also generic information for everyone. In Dutch, for everyone, we have got spots, also commercial spots, information of one size fits all. And the mass vaccination program in the beginning, if you are going to vaccine about millions of people with the vaccine, which is relatively new, then there will be more side effects, and there will be also more reports of side effects, and also in the media. And this could lead to a higher exposure of people with misinformation or with disinformation. And there was in that time, as we as GPs also vaccines used the AstraZeneca vaccination, and there was also some serious thrombose as a side effect. And we saw a lot of our patients, they say, no, we don't trust any kind of these vaccines. Also, the people who wanted to have the Pfizer or Moderna vaccines in the beginning, they also refused to get it because they said, I cannot understand, the information is very abstract for me. What does 0.1% chance of having thrombosis means? I could be that person. So, and we saw that people who were highly educated, they came and they get their vaccines. And what was also important at that time, that the trust in the government and the government policies, that was also deteriorated because of some scandals. Next slide, please. And with my colleague, Dr. Robin Peters, he was in internist, he's an internist at Erasmus MC. We saw that the people who don't get their vaccination, they came and a couple of weeks later into hospital. So, and we saw that all of the, we saw the information gap, and also that information was not accessible for everyone. So we wrote a letter for the Minister of Health, and it was very simple, just call for a clear and accessible information about vaccination. And a lot of colleagues from the Netherlands, about all of the medical communities, they supported us with our letter. Yes, next slide, please. And about 3 weeks later, the minister came to our practice, and we give a start sign to a different kind of to a more approachable vaccination campaign, and about and also folders in different languages. But if you have got some folders or flyers in different languages, you cannot reach those people. You have to, because they are not a lot of people, they cannot read. So we have to talk to the people. We have to go with them. And we created with Dr. Peters gezondheidskloof.nl. It's actually, yeah, healthgap.nl, just to try to connect the health professionals who wanted to give information about COVID-19 to the people in the mosques, in the marketplaces, and to a lot of those places. Next slide, please. So we this was actually, I've got some of the pictures of how we did it. There were in the morning, Saturday, about 7 Saturdays, we stand at the marketplace in Delfshaven, Rotterdam. a lot of people from migration background, but also people with who have difficulty with access to the greater vaccination locations. They come to visit us, and the doctors from across the Netherlands, but also mostly from Rotterdam, they gave information. It was not only GPs, but there were also medical students and also doctors from the hospital. Next slide, please. And it's and at that time we did about 116 of these sessions together, not only Rotterdam but also in province of Utrecht and in some other cities. And we are happy that at that time also doctors from other places in the Netherlands, they also did the same, and they also went to the easy accessible locations for people to give them information about vaccines, but also if they wanted, they could also give vaccines and by working together with the municipal health department. Next slide, please. Yeah, it was actually at the marketplace. It was the first time that we did it as a GPs, and also together with the support of our colleagues from the municipality and also colleagues from the hospital. It was also new for us. It was very at that time also very exciting for us. But we all checked and double checked all the procedure, because we wanted to give the people the information, but also the vaccination. It should be from the best quality for our patients. Next slide, please. Yeah, and we did the same thing about three neighborhoods in the Netherlands with low socioeconomic status, and there are some medical students. They also give the information. They also talked, and people came about every week. They came back, and we saw some in the first week that the father get the vaccination, and second week the mother, and after that the grandmother. So we saw, but that was the power of being at the same place and seeing the same people, and the people came and talk about that you were very easy accessible, and that was actually for us the key to, and that motivated us to get there. Next slide, please. And it's important, the Mr. here in green, how do you call it, in green vest. He's one of the community workers, and it's important to work with the community workers together, because they know how to contact the people. It's also important about the trust, that they can also trust you, because we as doctors were in public domain, but we have to also get connection with the people there. Next slide, please. Yeah, that's my colleague who started to about a year. He did the most of those sessions and give information. He was also living in the vicinity of the marketplace, and when he had free time, he went there and he gave a lot of information for people. Next slide, please. We also made we wanted to give something also to look what are the barriers for people, why they want to go to vaccinate themselves at a walk-in vaccination facility, but not at a larger vaccination facility by the government. And we asked the people when they were vaccinated, they were in the waiting area, and most of them said the accessibility of the vaccination facility, that was important for them to get vaccinated here, but also there was family influence in a positive or a negative manner, and fear was also very important, but there was no relationship with migration background. Next slide, please. Dr. Robin Peters and I thought, okay, we are getting to the people in the marketplaces, but what about the larger population? So it gives a start to the vaccinatie twijfel telephone, the DUIT telephone. Next slide, please, from the Erasmus MC. Next slide, please. And the vaccinatie twijfel telephone, and we give corona information about the corona vaccine. It was anonymous. People could call from all over the Netherlands to get information about the corona vaccine. Next slide, please. And yes, right now it's not only about the corona vaccine, but we also give information about HPV vaccines and also about influenza. At that time, we had also some international attention. The Guardian also made a report of this to look how what we have done and how we succeeded to contact the people who normally who are actually in need of reliable information from the medical professionals. Next slide, please. That's the next one. Yes. But I can see there's two things. The trust is important one. The working together with the general practitioners, but also with other academic hospitals is important, and also the availability and the easy accessibility of the independent information is important for people. And that was also of them, most of them, when if we asked them why did you contact us, that was the reason that they wanted to contact us for more information. Next slide, please. In the first week, there were about 1,000 calls each week. It was nationwide, and also some it's also in some other languages. And next slide. And this may be the most of the information which the calls which we got. It was about 29% regarding the vaccination and the personal health condition of people, mostly interaction with their diagnosis of cancer, but also about effectivity. And last but not the least, there were also informations. There were also doubts and fear of people about pregnancy, but also a desire to have children. And sometime, and I have my own conversation with someone from the province of Zeeland, and it was about 45 minutes of conversation, and she told me, "Doctor, I understand you give me the right information, but only one thing which I don't understand. I have got this this fear from misinformation, but I can't throw it away from my mind." Next one.
Shakib, can I ask you to finish? Because we
yes.
need to
Just,
move.
I've only got one slide. This next one, please. Yeah. This is Johan Cruijff. It's one of the most of you will know him. And he says that you can only see it, you can only understand if you see it. And it's very important for us just to see that a lot of, if we give one size fits all for a lot of people at the same time in a pandemic, we can miss the part of people who actually are at risk to get infected or to die from the infection. Thank you very much.
Thank you so much, Shakib, that you shared your important experiences and insights with us. I see a question in the Q&A, but I first want to give actually the floor to Catherine to reflect a little bit from her perspective, from the WHO Europe point of view, on our Dutch experiences.
Yes, I'm happy to do that. In fact, they're very aligned with what we've seen in many, many other places. I've been working in the field of vaccination for 10 years in behavioral and cultural insights within vaccination. And I think it aligns very well with what we're seeing here. On the one hand, often we need to overcome some of the practical barriers. So when we talk about the vaccination process, make it easy, make it convenient, make it accessible, overcome those barriers, because even though we, from a public health perspective and community, we think vaccination is the most important thing, it's really not top of mind or priority for a lot of people. So making it convenient is a way of reaching more people. However, when we get beyond that, there's been this notion that people are hesitant, and then we think we need to just provide them with a lot of information. And I think Shakib's presentation illustrates very well, and that's what we've seen in other places as well, that this is very complex, and it's got to do with some very fundamental issues of fear, of trust, of creating relationships with the health workers. And really what we see again and again and again, as we saw here again with these health workers who came to the streets in those neighborhoods week after week after week, building those relationships, whether it's in the streets or whether it's in the clinics. The health workers are absolutely key. And we've seen the same. It's rarely about a specific migrant community having certain let's say religious perspectives. Sometimes it is, but very often it's not about that. Sometimes it's about communities or individuals having certain fears, and they need to be overcome through building trust, offering the right type of information in the right places, in the right format, and then building those relations over time. And then it is possible also to reach underserved populations. That's what we've seen also. But it is not easy, and it takes time, and it takes effort.
Yes, thank you. Thank you, Catherine. Then now I go back to the Q&A questions. First of all, a question from Shilva from the EMC Rotterdam. That's more a comment than a question. She mentioned that that you can have a look at a very nice, I think, a very nice result of their study, and the link is in the chat. So I think you can all look at the Q&A there. Then Linda Janssen, she says, Catherine's presentation mentioned that refugees don't always identify themselves as refugees. Do people from underserved groups perceive themselves as underserved? And does that differ between certain groups? And maybe the second question to you also from Mariska Petrucciani, she asked also to Catherine to engage cultural mediators for the Ukraine refugees. Which type of organizations would do that in the countries you studied, and who identified and found those people? How were they embedded in healthcare? Well, maybe you can reflect on these two questions in the chat.
Yes. So the first one is such a good question / comment. I have been thinking about how I could maybe present this without using the word refugee, and then it's just a long explanation. People moving from Ukraine to host countries, and then maybe you as recipients wouldn't really understand what I was saying. But I so agree with you that we have to make sure that we're not putting people in boxes that they don't self-identify with, and words matter, language matters, and we have to be careful with using that type of categorizing people, maybe even stigmatizing people by putting them in groups. So I so agree with you. I think underserved is better than hard to reach or vulnerable. I sometimes use people who are experiencing disadvantage, but I think we haven't cracked that nut yet, and I think it's such a good question. And the other question is about the intercultural mediators. This has been an initiative initiated by the public health authorities in Romania, supported by WHO. So WHO has had, in the country office in Romania, has had a strong role in supporting the public health authorities in identifying people and also engaging intercultural mediators. And obviously, in all of these 5 countries, NGOs have been just indispensable and so important for the support that has been provided to people who have traveled to host countries. And that's also a very important feedback that we got in the interviews, that they're so happy with the support that they get from volunteers, NGOs.
Okay, thank you, Catherine. One last very quick question to Dr. Shakib from Alma. Tosman, if you think that your way of working can become part of the national strategies. And you have one.
Thank you very much. Yeah, thank you very much, Alma. I would say I hope not, but on the other hand, we know that overcome the health literacy and health gap is actually very takes a lot of time and maybe some generations. So yes, it's needed maybe in a different way, but it's needed because people trust their GPs and their doctors. But more than 90% of people in the Netherlands, they trust their doctors. I think we have to use this one as well, because the doctors, we should not only help the people when they are sick, but we can also do it when we can prevent it. My answer will be for this time, yes, and that should be one of the strategies in the pandemic.
Thank you. And with that, we come to the end of this webinar. I would like to thank all the speakers for sharing their insights and sharing how important it is to incorporate behavioral insights into public health strategies, and not only for COVID, but also for other public health issues. I would also like to thank all the speakers. I think Maaike will share, all the participants and all the listeners. You can find our report on our website, and it might also have been shared already in the chat, the link to the report. It will be online, and you can also share the video of this webinar that will be shared with you later today. Thank you very much, and keep up the good work, and hope to see you somewhere soon. Bye-bye. Thank you.
Thank you so much. Bye-bye.